Cool. So thanks everyone for the invitation to do a case report for everyone. It's been a while, so I have an adjunct professorship at the University of Illinois. I teach at the medical school and the pharmacy school over there. And so when I was given the opportunity to talk to wilderness medicine, as Skylar had told me, we have one of those groups at UIC, and I was thinking, what could be a pertinent topic to what we have going on today? And I know a year ago, we had Australian wildfires. And then even just before that, in the fall, we had California wildfires and also wildfires in this past fall too, on top of everything else that's been going on. So there was a case for this patient, 22-year-old African-American man who's presenting to the emergency room unconscious. His neighbors tell the admitting nurse that this particular patient had flown in from the East Coast. We're in California here. And what he had thought was that he had some back pain that he was complaining about, and he thought that he needed some fresh air. So he came out to California. He thought he could sleep on a new mattress. Maybe that would help with his back pain. That would help with all of the other problems that he was having. But other than that, that's really the only thing that we know about this patient, because he was found unconscious. Nobody really knows much else about him, except in his medical history, they find out that he has sickle cell trait. Now, one thing that EMS had told the admitting staff when he came in was that he had a seizure in the ambulance, and then he had a cardiac arrest. And so they did resuscitate him, and with CPR, after about 2 minutes, he did come back up. And so other than sickle cell trait, which isn't too uncommon for African-American descent, he also didn't have a medication list, and you wouldn't expect one from somebody who's 22 and presumably healthy. And for social history, we don't really know. We don't know if there was smoking. We don't know if he had been drinking, although you might maybe be able to tell from his breath, and illicit use was also unknown, but he was found unconscious with his sister. And so they were both in the house in the middle of the night, and then they were brought in to the emergency room. So when we look at physical exam, and by the way, for this handout, any time that you need to use any of these images, I have them all cleared. These are also ones that I also drew some of these images myself, so feel free to use them when you're later in your courses or during residency and also in fellowship. And so the physical exam for this patient, he was nonverbal. He was unable to respond to commands, but he was breathing spontaneously. Heart rate was a little high, 100. Blood pressure, hypotensive, 80/60. Temperature is normal. And because he was unconscious, they did a head CT just to make sure that there wasn't some kind of head injury. Maybe, you never know, during a fire, something might have fallen and might have hit him in the head. So we're not 100% sure, but it turned out it was okay. So nothing with the problem there. Now, throughout the emergency room course, which happened fairly quickly, his blood pressure rose back up to 120/80 without fluid repletion and without administration of epinephrine. And so when he was resuscitated, it was just with CPR. Now, when they did the labs on admission, they found out, and so I was talking with Skylar on Tuesday about the fish bones here. So these are called fish bones, and I guess first-year students haven't yet seen them. So I have some references down here. I didn't have space to put in reference values, which do change just a little bit on the lower and the high ends, depending on institution. Overall, ballpark, they're about the same. And so instead of the reference values, I put in green and red. So red is out of bounds. It could be too high or too low. And if you really want to look up those reference values, then they're there. So serum sodium and potassium, no problem. Okay. Chloride is also okay, but when we go into bicarbonate, we find out that bicarbonate is low. And so we know bicarbonate is a base. So if your base is low and we're in a closed system in the body, then your acid is probably going to be high, okay? And when we look at blood urea nitrogen and creatinine, we're looking at kidney function. So his creatinine was kind of high. So there could be something going on with his kidneys. If you take the ratio of blood urea nitrogen and creatinine, you can also find out if the patient is dehydrated or not. But in this case, seems like he's all right. And so just looking a little bit further into some more labs, we confirm that, hey, this person is acidotic. Normal blood pH is usually around 7.4, 7.35 if you want. But if it's lower, then that means that there's more acid in his blood. And also his lactate is kind of high, but that shouldn't be surprising, right? When somebody has a seizure, right, they have a chaotic discharge. And so you have a lot of metabolic activity happening. And when you have that, your muscles start to fire off. And afterwards, you might find out that there's going to be a lot of lactic acid that's floating around in the blood. And also, if there's a cardiac arrest, post-arrest, because of ischemia and limited perfusion, you're going to find out that lactate could also be high. So we have some clues as to what's happening here to the patient just based on these labs right here. And if we look at it, there's something called an anion gap. And so if we look here, right, we know that sodium is a positive charge, potassium is a positive charge, chloride's negative, and bicarbonate is also negative. Let's just say potassium is too small compared to sodium, so we'll ignore it. So if we take 139 minus 98 minus 19, you'll find out that his anion gap is high. So that means that he has some kind of metabolic acidosis that's caused, it's caused with a high anion gap. And so that means that there's probably something in his body that's causing the problem. And so when we know that somebody's coming from a burning house and had been breathing in a lot of smoke, then we got to think, okay, there's toxic gases here. And so a lot of times, I know when I think of toxic gas inhalation, I'm thinking of like the long-term effects. You might be thinking, oh, there might be, heavy metals in that cloud of smoke that you might be breathing, or something in there that you breathe is going to be causing cancer. And that could be right. But in this case, in the emergency room, you're really just looking at what the acute problem is. This person's unconscious, they're not responsive, so something's up. And when you look at it, young man with no past medical history is unconscious, just had a seizure and their heart just stopped. A lot of times, if it wasn't from a burning house, you might think that maybe they did take something or maybe they drank something and you're not 100% sure. And especially when he's there with his sister, his neighbors were outside of the house, so they had no idea what was going on inside the house. And if his sister can't say anything and he can't say anything, well, then maybe something was there. But also, if we look up here in the urine screen, this is the drug screen here. We didn't see anything, right? So there's no illicits. There's probably no alcohol in there either. If you look closely on here, and then if you look at the creatinine, you might see if you know about kidney function, and later down the line, you'll learn more about it. There could be something going on here too with his kidneys, but we're not 100% sure. So we know that there's probably no alcohol there. And so what it means is that, well, what else could he have taken that you wouldn't be able to see or be able to smell, right? And maybe that drug screen may have missed something that you're not looking for, right? Like Tylenol or aspirin. Maybe they downed a whole bottle. And because the house was burning down, the EMS didn't find any empty bottles next to them. Who knows, right? So you could do that test if you would want, just to rule out that diagnosis. And if you look at the altered mental status and the seizures, you could also think organophosphate exposure. That's pretty rare here in the United States. So typically you'll find somebody from maybe like South Asia or Southeast Asia coming to visit, and they just had an exposure to some pesticides maybe just a couple days earlier. And so if you look at their skin, you might find it discolored, and that could be the pesticides going right through the skin, absorbing right into the bloodstream, causing some anticholinergic toxicity. And so then you could get the altered mental status. But for this patient, I mean, maybe he was taking a hike out in the woods, but I wouldn't suspect that California has those pesticides either. So organophosphate exposure, maybe not, but it's something to have on your list to think, this could be an issue. There's also tricyclic antidepressants, which in this patient, probably not. And then just for completion's sake, I put in isoniazid and strychnine. Those are things that you put on the list. And it's like, if you do a to-do list, you write down the things that you've already done just so you can cross them out and, have yourself covered. So I don't think that those are likely, but those could be something that could be down the line for a different patient. So because we're coming in from a burning house, right? We see presence of gas. There could be asphyxiants. Maybe they left the stove on, right? That it wasn't on fire, but it was just letting gas out. So it could be like methane or propane. There's also hydrogen sulfide gas. Could be possible in this case, but really in the case of a burning house that's not industrial, that would be where arsine comes from, you're looking at cyanide and carbon monoxide that you're breathing in that might knock the patient out unconscious and cause some of the problems that we see in this 22-year-old man. So what are the tests that you want to do to make sure that we could be looking at cyanide and carbon monoxide poisoning? Well, glucose could be there to rule out hypoglycemia for altered mental status. When we look at this, right, there's no glucose here. So a point of care finger stick test, we can get that pretty easily, pretty quick. And so in this case, it wasn't hypoglycemia. You can also look at the aspirin and acetaminophen levels. So didn't have it. Serum lactate we did see that it's high. So he has lactic acidosis. And so in this case, EMS, they would have taken presumptive measures for this patient. And we're going to talk a little bit more about how that cyanide poisoning would be treated. But what does cyanide do? When I was talking with Skylar on Tuesday, she had mentioned that you had some biochem classes and learning more about mechanisms of disease. And the one thing that I always find interesting whenever I do the lectures, right? You know, the longer that you're in this space and the longer that, you know, you're always learning and looking more, you're going to find out that sometimes paradigms shift and some of the things that you learn, they're not wrong, you know, but they might have changed ever so slightly because of how the scientific understanding has come out about it. And so just give you an example in like the pandemic, right? We hear about the plague and the Black Death and, you know, the plague doctors with the beaks, right? And then they put, I guess, like some rose petals in there. Is it really all that different from the masks that we have now? You know, it kind of seems like the same ideas are coming back. And a lot of times we make fun of old medicine to say, oh, you know, didn't you know they used to bloodlet or, you know, leeches? And fun fact, you know, depending on which clerkships you choose, you might see that leeches are still used in some cases. So when it comes to cyanide and how it's taught today, there's a couple things that are a little bit different now because we treat it differently now than we did 20 years ago. So cyanide is a mitochondrial toxin, and it usually comes in the solid salt form, and potassium cyanide can be used in industrial purposes as a pesticide, right? And it comes in different forms. You know, you can also get gas as cyanide, just pure cyanide gas, or in a liquid form. And also you get cyanogens. So if you've ever heard of the apricots and peach pits, you hear about little kids just eating peach pits and then they get cyanide poisoning. And that's because it's a cyanogen, is that there's things in there that get metabolized into cyanide in the body, which then cause the poisoning. And another thing too is in the context of, I guess, pseudoscience, there was something called vitamin B17 Laetrile that people thought was falsely pushed as an anti-cancer treatment, and that gets broken down to cyanide in the body. So I guess technically it does kill the cancer, but it kills the patient too. And so keep that in mind when you have patients that could have cyanide poisoning. And so just a little bit of background on here, right? Cyanide is still legal to use as a method of execution and capital punishment. And it was last used in 1999 in Arizona. It's not illegal. It's still legal here today. And the first time it was used was 75 years before, in 1924 in Nevada. And the report of the person being executed by the cyanide, they said that he was sitting in the chamber. They had 4 pounds of potassium cyanide, salt, and they mixed it with sulfuric acid. And within a couple seconds of the gas entering the chamber, the person was unconscious. And within 20 minutes, they aired out the chamber. And then 2 hours later, they thought he was dead. And so they brought him to the hospital, and the people who were going to do the autopsy on him refused to do that autopsy because they thought that the gas would come out of his body and then poison everyone who was doing the autopsy. And so the question is that if this person, within 5 seconds of coming in contact with the lethal gas in the chamber, how does it work that quickly? How does cyanide gas just go into the body, and how does it do its thing, right? Well, just like in this execution method, we had cyanide, solid salt, that was mixed with sulfuric acid. And we know sulfuric acid is one of the strongest acids because at least for it's diprotic. but in the monoprotic form, that first hydrogen dissociates completely. And so you drive that reaction to the point where you get hydrogen cyanide gas. And so in acidic conditions, like sulfuric acid is acidic, the sulfuric acid, it'll completely dissociate. And then you see that hydrogen cyanide in that acidic environment stays as hydrogen cyanide. It doesn't become cyanide ion. And what does that mean, right? So in UpToDate, which may be used as a crutch, as like, something that you're looking onto as you're on rotations, as you're on, when you're in your residency, or if you're on the medicine service, you're totally going to be looking at UpToDate to make sure you're getting some of these things right. And that's totally fine. And so what I was talking with Skylar on Tuesday about was that some of the things that you're going to read in things like UpToDate are going to be written by your colleagues. And, when you look at this, you're going to, if you know them, you're going to know around the time that they did their training, around how long they've been practicing. And then that might uncover some of the ways of thinking that they might have because of when they entered into the profession. And so when you look at this, right, in UpToDate right now, if you look it up, if you have access, in cyanide poisoning entry under pathophysiology, you'll find out that it says that cyanide binds to ferric ion of cytochrome oxidase A3 in the mitochondria, and it inhibits mitochondrial cytochrome complex, which means then it uncouples oxidative phosphorylation and doesn't let the mitochondria produce ATP. So that mitochondria, quote unquote, can't be the powerhouse of the cell anymore. And so when you switch to anaerobic metabolism, that's when your lactate levels go up, lactic acid gets produced, and then you get acidosis. And so the thing is, if it's taught that cyanide ion binds to iron, ferric ion in cytochrome oxidase to uncouple that oxidative phosphorylation, are we sure exactly that's how that happens? Because if we look at it, physiologic pH is around 7.4, 7.35. And so if we're at pH of 7 here and we go up, well, most of the cyanide is hydrogen cyanide gas. It's not an ion, right? And also because we would be acidotic in that patient, well, we're also probably going to be closer to here, right? And so if we're closer to here, then there's a lot more of the cyanide that wouldn't exist in ion form. It would be hydrogen cyanide. And so how is that binding to iron if that's the case? Is it really binding to iron? We're not 100% sure, right? And so this mechanism that's described of how cyanide is toxic in the body could reflect how it used to be treated, because how it used to be treated was you turn that iron, that Fe3+, to Fe2+. You reduce it. And by doing that, then you can bind that cyanide in the blood cells. And by doing that, then you have a less toxic form of cyanide. That's how the old treatment paradigm was. It didn't always work. And so this might be why it's written in UpToDate like this. And so when we look at it, what does it exactly bind to? If it's not iron, it's got to bind to something, right? I mean, it's causing problems in the body. So what would cyanide be doing? So if we look, and in this handout, if you've downloaded it, I have anything that's underlined is hyperlinked. So click there, and that's where the references are. I wasn't able to get like a full reference list at the end. And I think it's easier to have it in line. You can just click, and then it'll be able to open your browser and bring you to the source. And so when we look at this diagram of mitochondria, right? We know that there's 4 complexes that help in this electron transport chain that pumps protons from the mitochondrial matrix into the intermembrane space. And I know there's a lot of talk. If you go on med Twitter, you'll find some people saying, well, I didn't need to learn the TCA cycle to do my job, to practice in my subspecialty. And that's fine, right? I totally understand. When you're in toxicology or oncology, TCA cycle and mitochondria, you got to know it on top of knowing all the data too. So this is just, this is part of this branch of medicine, if you will. Now, if you look, the 4 different complexes, their main goal is to pump protons into the intermembrane space. And by pumping those protons in here, in this enzyme for ATPase, what they do is that they create an electrochemical gradient of pumping all these protons in so that it wants to escape out. And by going through this pore in the membrane, that's where the ATP is created. Now, when we look at up-to-date cytochrome oxidase A3, so that is complex 4. And so when we look at complex 4, it receives an electron that gets transferred through the pumping of this proton on complex 3 onto cytochrome C. And what we know is that on complex 4, on cytochrome oxidase, there's actually copper ions in there. And copper ions are the ones that accept this electron, which then shuffle into this binuclear center of cytochrome oxidase. And by shuffling electrons around in this binuclear center, it then turns oxygen to water and then helps pump that extra 2 protons into the intermembrane space. And so if we look, right, we have copper in cytochrome oxidase in the binuclear center. We also have copper, but it also binds to iron. And so there's a little bit of a mechanism of electron exchange between iron using oxygen and then oxidizing and reducing copper in order to shuffle those electrons around. And so if we look at some of the older literature and some of the more benchtop experiments that have come around, they found actually that cyanide binds to copper. And originally they didn't know it was copper. They said it was binding to something inside one of these mitochondrial enzymes. And they weren't 100% sure back then. They thought maybe it was something that has to do with sulfur because of how cyanide used to be treated. They tried to give sulfur donors, right, to bind onto the cyanide ion, which is what they thought to get rid of it. But that didn't seem like what was happening, right? And so when we look, it binds copper first and then binds iron. And then it does its toxicity, right? So let's look, right? We find that there's different places where it can bind. And it looks like it binds first to copper, then iron, and potentially some kind of sulfur linkage. But from what we know inside this binuclear center, we're looking at copper and iron and initially binding to copper. And so when it says up here in up to date that it does bind to iron, ferric ion, that might be true, but that might be somewhere later down the line. And that might not be clinically significant in the case of how cyanide is toxic. And because of that, now we know we can treat it a little bit differently. And so going further, if we go back to up to date, what we can see here is that they add on another thing at the very end of the pathophysiology section. They say cyanide has primary affinity for the ferric Fe3 plus iron. Some of it may bind to the reduced ferrous ion of hemoglobin and form cyanohemoglobin, which can't transport oxygen, which would have been how they would have treated cyanide poisoning to begin with, and thereby further exacerbating tissue hypoxia. And so if you think about it, if you shift and you reduce iron from ferrous or ferric to ferrous, then what you're going to have is that you're going to have an oxygen saturation gap. And if you have that oxygen saturation gap, then theoretically, then a lot of that cyanide would bind into Fe2+. And by doing that, then you could actually shift the reaction one way to produce more iron 2+. And you would theoretically have an oxygen saturation gap because oxygen doesn't bind to Fe2+, it binds to Fe3+. And so if you have that, then there could be evidence for this happening, but it doesn't seem like that's exactly how it happens. And so I challenge you to read this article that was written in '91 about looking for a % saturation gap and also looking for the creation of cyanohemoglobin, right? Because it seems like looking through this, it's been repeated all throughout these years, and it's even written in up to date. And if you look at this source number 16, it's a textbook, and the textbook also doesn't have a citation tagged onto it. So where did that come from, right? Are we 100% sure this is how it happens? And like I said, this is written this way because of how we used to treat cyanide poisoning. So that's enough for cyanide right now. The way that it's treated actually confounds with the next problem, which is carbon monoxide poisoning. So again, burning house, breathing in cyanide gas, breathing in carbon monoxide. So the point of the cyanide stuff was to think more about a lot of the stuff that we learned. Some of it is still right, some of it's still true, but it might be a little bit different because of our understanding has evolved a little bit. So you can also apply that same reasoning here. Carbon monoxide binds to iron in hemoglobin or in heme, and it has stronger affinity for it than oxygen does. And because it'd be a competitive inhibitor, it would actually bind in and kick out the oxygen. And then that way you wouldn't be able to get any tissue perfusion. You'd have ischemia. And when you have that, then you're basically, it's almost like you're suffocating, right? And that's not the only way that carbon monoxide is poisonous. We've also found out that you can get some neuroinflammation that happens as a result of this hypoxia that could come up from carbon monoxide. And so there's a little bit of a diagram here. I don't know if you've had immunology course yet, but you'll learn that some of the neutrophils will roll along the endothelial lining of the blood vessel. And as it rolls along, it could degranulate and then also let go of a lot of histamine, but then that induces an inflammatory reaction, which if you have that around nerve cells, you might have some neuroinflammation and damage that could result from it. So carbon monoxide poisoning isn't just necessarily ischemia that results. It could also have an inflammatory mechanism associated with it. And so for diagnosis of carbon monoxide, you would have an acute poisoning in this case, because this person's coming from a burning house. If it was somebody who had left, there's chronic carbon monoxide poisoning that's a lot harder to diagnose because the person themselves wouldn't know that they're being exposed. And also, it's not something that you typically think of. And so when you have that binding of carbon monoxide to heme, you create a different compound, the carboxyhemoglobin. And you can do a test on that. It's bright red. You can see it. If you do it on the test, you'll be able to find it. But the problem is, and this brings us back to cyanide poisoning treatment, is that the treatment for cyanide poisoning is also the color of red. And having the two together in the blood would then mean that you might not necessarily find carboxyhemoglobin in the case of somebody who has had cyanide poisoning and has been treated for it. And so this brings us back to cyanide, because EMS, a lot of times when somebody's coming from a burning house, they might take the presumptive measure and give hydroxycobalamin, which is the treatment for cyanide poisoning. And so if you know some of the vitamins, cobalamin is vitamin B12, and the hydroxy part here is this moiety right here that's bound to the cobalt. And so being a form of vitamin B12, it's probably not going to be toxic if you give it. So if in case there's a suspected cyanide poisoning, you give it, maybe not too much issue that could come with it. You would give the whole vial in the adult. There was a case report of an infant getting 5 grams and they turned red and then they were discharged the day later. But you know, the adult dosing and pediatric dosing are different. Sometimes you might learn in class that kids are small adults. That's not always true. Now, when you have hydroxycobalamin, which is red, and carboxyhemoglobin, which is red, you might have falsely elevated or falsely depressed carboxyhemoglobin levels. So you're not 100% sure. And in this case, you would give the hyperbaric oxygen. What you would do is try to overcome the competitive inhibition that you would get from the carbon monoxide on top of getting this hydroxycobalamin for the cyanide poisoning. Now, when we look at it, because we know cyanide now binds copper and it also binds iron too, it looks like it can bind to cobalt, another metal on here. And so when we give it, we get cyanocobalamin, which is the injected form of vitamin B12 that you give for deficiency. And so because we treat cyanide poisoning this way, it's a little bit different than reducing the heme in the blood to get it to get the cyanide to bind and form cyanohemoglobin. We don't typically do that anymore. I think some places do, but in general now it's usually treated with a hydroxycobalamin injection from a vial, and that's been that way since around 2006. And so moving on for this case, the clinical course is overall uncomplicated in this patient. And so in here, I'll talk a little bit more about this at the end, is that it was complicated, or was it? Was there something else that you may have seen in the labs that could have changed a couple of things? And so we'll talk more about this at the end. And so neurologic course improved quickly. The patient came back up. He was responsive. He was able to talk. Overall, appears to be a very healthy 22-year-old man. So non-smoker, no alcohol usage, no illicit use. And so they were discharged by saying, hey, this hydroxycobalamin can cause your urine to be red for up to 5 weeks. So, don't be worried if you urinate and you see red everywhere in the toilet. It's probably not a big deal, is what they told him. And so he left California and returned home to the East Coast. And so looking at this, it seems like he was okay, right? Everything was good, that his cyanide poisoning was addressed, his carbon monoxide poisoning was addressed, altered mental status, all that was fine, right? Except it didn't really get to the core of why he was in the West Coast in the first place. His neighbor had mentioned to the admitting staff that he had back pain and he had right-sided pain, right? And he wasn't sure what it was. He thought maybe it was his mattress. Get some fresh air out west, sleep on a different mattress at his sister's house, maybe things would be better. But it turned out they actually weren't better. And when he was thinking about it, he was already urinating red before he got the hydroxycobalamin. He was actually kind of concerned about it. He wasn't sure what was going on. And so by doing that, and also having it confounded now by thinking that he could be urinating red because of his prior toxic gas treatment, he was thinking, okay, well, now I'm peeing what seems to be blood. And it's been 2 months now. It's longer than that 5 weeks that the doctors had told me about. And so what do I do? And at this time, his back pain was worsening. His sides were getting worse. He was having some trouble breathing and he was wheezing and he wasn't sure what was going on. And the pain was getting really bad. And his urine was getting deeper red and he wasn't sure what was going on. So he brings himself back to the emergency room, a different one near where he lives. And they find out that there's blood in his urine. But he doesn't have a fever. He doesn't have white blood cells. So it's probably not being caused by an infection. And so what they did notice is that this person, he was an African-American man and he had sickle cell trait. And again, sickle cell trait is not uncommon for somebody of African-American descent. So they thought about it and they said, well, now we're going to have to look at the kidney and see what's going on. So they did a CT in his abdomen and they found a mass in his right kidney. And when they looked at it, they said, okay, there could be something there. And he had trouble breathing, so they did a chest CT, and they found out, oh, he has nodules in his lungs. And they found out there's also some lymph node involvement here too. So in the emergency room, they find that there is a malignancy that the primary could be coming from his kidney. I'm not 100% sure, but they say, well, in the emergency room, we're looking at potentially metastatic renal cell carcinoma. And typically, you don't want to diagnose cancer in the emergency room because you don't have enough equipment and enough time. It's really the time to look through it and to understand that this is a stage 4 cancer patient. He's only 22. Where did that come from? And if he had been having his pain before his toxic gas inhalation, what was going on before that time, right? So he was discharged with a referral to urology, outpatient. And so he ended up going to a local academic center at a cancer center, and they did a renal biopsy, and they found a high-grade adenocarcinoma. So it's blocking some of the ducts in the kidney and has a desmoplastic background. So what that is, it's like a fibrous shell. You find it in pancreatic cancer. It's like this, it's like scar tissue almost. It's really hard and fibrous, and it's really difficult to get medicines through it. And that's what they found in his right kidney. And so they wanted to do some genotyping because we're in the era of medicine now. Precision medicine is what they call it. So they're able to look at the different mutations that this patient has. And so they look And so, there's some things that are positive. These are not super specific. There's some things that are positive, which means that they're being amplified in this tumor of his. And they also find that some things are missing. So, he's lost the function of those genes. And then finally, the medical oncologist, knowing that this kind of kidney cancer is kind of suspect, given this patient's demographics, they order another test for something called INI1, which finds out it's negative. And by negative, it means that it's not there. He doesn't have the function of INI1. And because they have that's one characteristic. And then he also has sickle cell trait. Given that this patient is a young African-American man, means that this particular kidney cancer is not the common clear cell renal cell carcinoma that's typically found in kidney cancer patients. It's renal medullary carcinoma. And having lymph and pulmonary involvement means that this is a stage 4 cancer in the patient. It's already spread, widespread metastases throughout. It's already broken off from its primary site. And this is the kidney cancer that this patient has. So what exactly is renal cell carcinoma? So it was first formally described in 1995 in a paper called Renal Medullary Carcinoma, the 7th sickle cell nephropathy. But realistically, this cancer has already been discussed as far back as the 70s, where there were some case reports talking about this mysterious kidney cancer that people weren't really sure what it was. And so recently we had a review article that was put out looking at different case reports and different kidney cancers that are coming out. And so in 1982, there was a 22-year-old African-American man with poorly differentiated carcinoma with papillary and glandular features with an extension of to perinephric fat. And they weren't sure, maybe it was some kind of collecting duct carcinoma. They weren't sure. They said, well, this is a little bit different than the typical kidney cancer that we see. There are a lot of patients who have sickle cell trait or disease that end up having this cancer. They're usually young men, and when they get it, it's usually already stage 4 because they don't show the signs and symptoms of this particular cancer until really it might almost just be too late. And so in looking at this 1982 patient, we can see some of the pathology slides that they described. They just weren't sure what it is. But at looking at it now, it does almost kind of look like it was renal medullary carcinoma that could have been missed. And so they're not 100% sure, but looking at it, it really does seem so. And this patient developed widespread metastases, and within 3 months of surgery, he died. And so what you find is that if you go back into the literature trying to find renal medullary carcinoma, you don't actually find too many instances and reports of it. And actually, if you look up collecting duct carcinoma, you'll find out that there's a lot more collecting duct carcinoma. But knowing what we know now, it might have actually been, if it was a sickle cell patient and a young, predominantly men, but it also happens in women, young African-American people, you find that, hey, maybe this cancer may not be as rare as once thought. And so it's usually associated with sickle cell disease or trait. And what is meant by that, right? So we know that in sickle cell, a blood cell will become sickle shaped. In disease, in the peripheral blood, they'll sickle everywhere. It causes pain. And if I know here in DC, there's sickle cell centers around here. Where I was in Chicago, major sickle cell center there too. And so when you have blood cells that become sickle shaped, you get problems that manifest because of the shape that they make. And so when we look at it, right, sickle cell disease is where the blood cells sickle everywhere. In the peripheral blood, they cause the pain. But sickle cell trait, it's a little bit deceptive, the name, because you hear trait isn't disease. So if it's not disease, then it's fine, right? Well, it could be fine, but what we know is that the disease is the homozygous variant. So both of the alleles have the mutation of sickle. In sickle cell trait, it's the heterozygous variant, which means that one gene is sickle and one gene is not sickle. And by having that means that the blood cells aren't going to really sickle anywhere, right? In most other places, they're not going to become that strange shape that can cause problems. Right? And so they don't always sickle in trait, but sometimes they do. And when would they sickle? Well, they could start to sickle when the conditions are right. And when we look at kidney physiology, and excuse some of the language on here isn't quite as academic, but it gets the point across, right? When we look at the kidney, how it concentrates urine is that when it goes into the medulla, the medulla starts to become hypertonic and hypoxic. And when it becomes hypertonic, you know that water goes from, it goes to the concentration gradient. So if you have a less salty region, a less concentrated region, and you have a more concentrated region with more, let's say, sodium chloride, you're going to know that the water is going to flow towards where there's more sodium chloride and try to dilute that. And that's how the kidneys concentrate urine, is that they try to make one part of the very deep inner medulla very salty so that it pulls out a lot of water. And so when you don't have a lot of water, the inside of your kidney becomes very quote unquote salty. And when it becomes really salty, it pulls out a lot of that water to reabsorb all of it. And so that's why when you're dehydrated, you haven't had a lot of water to drink for that day, you're going to have very concentrated, very deep yellow urine, right? And so by knowing this part of kidney physiology, the inner medulla of the kidney is so hypertonic and so hypoxic to the point where normal cells wouldn't be able to tolerate that kind of environment, right? But kidney medulla cells, they can tolerate that environment. And by having that quality to them, it means that some of their DNA repair mechanisms that come up in cells in that region could be expressed at a degree that's higher than the cells that would be up here in the outer medulla, right? As we go, as we get further out, we'll find that the cells will be a little bit different, right? And so inner medulla is so hypoxic to be anoxic PO2 of 0. And what's the difference between hypoxia and hypoxemia? I'll let you answer that question. We have in the kidney tissue a very harsh environment for cells to survive. And so what happens is when you have the blood supply into the kidney, that's not the blood that's becoming urine, that's the blood that's supplying oxygen to these parts of the kidneys, what you'll find is that in this hypoxic region where there's very little oxygen, it's going to make it so that the cells start to sickle, right? In sickle cell trait, they're not sickling pretty much anywhere in the body except for here, because in this part of the body, the conditions are so difficult for cells to operate that in this case, the hemoglobin changes its conformation just a little bit because of the hypoxia. Now all of a sudden it's a sickle shape. And when it's a sickle shape, it starts to block flow and cause microvascular occlusions. And then you get some renal infarcts. You get some localized infarctions that happen. And so in sickle cell trait patients, what you'll find out is that in the kidneys, in the inner medulla, right? This is somebody who may not have had renal medullary carcinoma. A regular patient who has sickle cell trait, if you look at their kidneys, you will find those sickle cells there. You won't find them anywhere else except there. And so when you have this microvascular occlusion into the inner medulla, what happens then is that it becomes very difficult for these cells to really survive, because now not only are they in an environment with limited oxygen and a lot of sodium chloride, they're in an environment where there's no blood flow, right? And so this ischemia can start to cause problems, as we're going to see. So what we know is that a high presence of sodium chloride anywhere causes DNA breaks inside cells. And because the cells of the kidney medulla can tolerate this, they have mechanisms that can repair these breaks by default that cells maybe up here in the cortex might not have, right? And so this hypertonicity inhibits the double strand break repair. And so, like I said, in the cortex, they wouldn't be able to do it. In the inner medulla, they might be able to do it. The problem is that when you have those sickled cells blocking flow into the inner medulla, you're going to start to lose those high fidelity repair mechanisms that would happen in normal function. And what happens is that, well, the cells still need to repair something, right? So they might not use the really good repair mechanisms, they might use the backups. And so when they use the backup mechanism to repair, that's when you start to get errors, because things might start to slip. You know, it might take one thing from one gene from one chromosome and accidentally attach it to a different chromosome when the cell replicates. Then you start to have these problems, and then maybe some of the genes might be deleted, right? Some of the base pairs might be deleted, and you're not 100% sure exactly what's going on. But now, all of a sudden, because you have this microvascular occlusion, you have some differences that are starting to happen in the cells that are replicating in this region in the inner medulla. And so what happens is that, well, we know that renal medullary carcinoma, there is this loss of INI1. And to add to the confusion, if you look in the literature for INI1, you'll be missing a lot of articles because it's not just called INI1, it's also called SMARCB1 and also called BAF47. And all of these are part of something called a Swiss sniff complex. And I think this was discovered in Drosophila, so the little fruit flies that you may have heard of in your undergrad bio classes. And so SMARCB1 is the Swiss sniff-related, matrix-associated, actin-dependent regulator of chromatin, subfamily B, member 1. And what that means is that SMARCB1 is part of a larger complex. And this complex, it uses ATP to relieve some of the pressure that happens when DNA is wound up and bound into its complex or compact form. And by relieving some of that pressure, it helps to make sure that things aren't replicated that shouldn't be replicated. So you can call it a tumor suppressor gene. And so by that word tumor suppressor gene, it means exactly what the name says. It doesn't allow the cell to replicate inappropriately, right? And remember now, we're talking about a cancer where this is missing. So this protein is gone, which means that it doesn't do its function, and that now the cell could potentially start to replicate inappropriately. It's not getting suppressed. And so we know that INI1 loss happens in 100% of RMC cases. I have this linked. You can read that paper and to look at this proposed pathophysiology and mechanism of this disease. So why this particular gene? Why was it SMARCB1 that's lost in this particular kidney cancer? So, well, we know that we've sequenced the human genome, right? We know where exactly this gene is. It's on chromosome 22. And so if we look at chromosome 22, this particular region on 11.2 happens to have some qualities that make it so that backup DNA repair, which is what's induced because of this microvascular occlusion that happens up here, because these DNA breaks are now being repaired by the backup mechanism, what we get is you're going to have translocations because of the nature of that locus. So you have chromosome 22, there's a lot of palindromic repeats. So that means that you could almost turn something backwards by accident and not know it. And when you're replicating in an environment like this with high stress, it makes it very plausible that it's going to happen. And so it's also susceptible to microdeletions here too. And so when you have these low fidelity repair mechanisms that happen, what you get is that you're going to get parts of chromosome 22 is going to start showing up on other chromosomes because of the mistakes in DNA replication. So in this region, we know that there's at least 2 diseases that are very common. This 22q11.2 deletion syndrome, which is also known as DeGeorge syndrome or Cat's-eye syndrome. It's characterized by heart defects, hypoparathyroidism, and thymus gland dysfunction. And what you find is that it's the most common birth defect that you can get, most common microdeletion syndrome. So 1 out of 1,000 live births will have it. You also have something you may have learned about called the Philadelphia chromosome. So what that is the translocation of material from chromosome 22 onto chromosome number 9. And this translocation is it causes this chronic myeloid leukemia. And you'll find that it's right here, BCR, and it's right next to SMARCB1 on chromosome 22, and BCR is breakpoint cluster region. And because of that name, we know that that's a point where a lot of things could essentially get translocated from this chromosome to others. And so when you've moved the entire gene of SMARCB1 accidentally to somewhere else, SMARCB1 is the protein itself is never made. And so because it's a tumor suppressor and it's not being made anymore, it's not suppressing a tumor, that's where then you start to grow this cancer, specifically in the setting of sickle cell trait and disease. And so have a proposed mechanism here of how that happens. You know, we're blocking the blood flow because of the way that the kidney is set up and because of this genetic mutation that happens in the red blood cells that changes the conformation of hemoglobin ever so slightly to change it into a sickle cell shape so that they clump up and they start to block flow, and then they start to induce backup DNA repair mechanisms into the inner medulla of the kidney. And because of the way that SMARCB1 is set up on the human genome and where it is in chromosome 22, now you start to have the deletion of it, which then when you don't have a tumor suppressor gene and you lose both copies of the gene, you have this, what they call the two-hit hypothesis of how cancer develops, specifically for the loss of function when it comes to tumor suppressors. And so then now you have the development of renal medullary carcinoma, and it has started to metastasize in this patient. And so what do? And because it's not like the other kidney cancers, when they wrote the descriptions back in the 70s, when they wrote this first official description in 1995, they knew that you couldn't treat it like other kidney cancers. And that still holds, even though kidney cancer itself has changed a lot in the last 25 years. The first line treatment in the last 7 years has changed maybe 15 times. And so that still isn't, it's completely refractory. There's no response rate using what's typically done for clear cell renal cell carcinoma. And so what they do now still, unfortunately for this cancer, is they use chemotherapy, but the survival still isn't very good. And usually chemotherapy should be given before nephrectomy. And this is according to kidney medical oncology specialists. And the reason for it is because if you take out the kidney, the patient has to recover from the surgery before they can start to tolerate these kinds of chemotherapies. And unfortunately, by the time you give them enough to recover, that cancer, if it's already metastasized to the lungs and has lymph node involvement, you can reasonably expect, even you've taken the kidney out, there's micrometastatic disease. So those cells that are infected may have already started going around in the body, and then you'll have widespread metastases. And that's what happens in a majority of the patients who get the nephrectomy first. And so with these chemotherapies, they're pretty, they're similar in efficacy because it's chemotherapy, different toxicity profiles. So that just depends on what the patient is willing and able to tolerate. And so the final thing I want to talk about in this case is that we had an African-American man. And in this case, there is some health disparities for this patient in the context of sickle cell disease. So as I was talking with Skylar, if you have a social medicine class, you're going to find out that it's not necessarily the biases that come up, but it's more so that in, I guess in the last 20 or 30 years, right, since the 1970s, 50 years now, since then, you've had a building body of evidence in a particular cancer that was misidentified. It was misidentified as collecting duct carcinoma. It looks a lot like it. Renal medullary carcinoma and CDC look very similar under microscopes. But the thing is that if you see that the patient has sickle cell, is a young African-American person, you might suspect that maybe that wasn't collecting duct carcinoma, but it's really hard to tell now because if we don't have the pathology slides, you can't order a new test for INI1 in these patients because they're not alive anymore. So because of that, this could be a disparity because even if you look on Wikipedia, it said that to date, I think there was only like 40 published cases of renal medullary carcinoma in literature, but it's really coming out that there's a lot more. The second disparity would be that the name sickle cell trait could be a misnomer, but this is a really difficult one to do because sickle cell disease is where the blood cells sickle everywhere in the peripheral blood. But if you have trait, you don't want to stigmatize the person to tell them that they have a disease because majority of the patients who have the trait aren't going to get this cancer. It's select people who do end up getting the cancer that end up having the sickle cell trait as a consequence of it. But when you look at it, do you stigmatize the patient or not even stigmatize the patient? They might even think themselves, I have some kind of diagnosis when in reality, it's a heterozygous variant of a genetic mutation that's not necessarily harmful. And so, which one do you do, right? It's difficult, and that in itself is a health disparity. The other one too is that a lot of sickle cell patients are hard to pick out. The signs and symptoms are non-specific. Sometimes you don't know if this patient has sickle cell, but yet they're presenting with signs and symptoms that wouldn't be explained otherwise. And so by having that, you have this patient who had back pain that was masked by toxic gas inhalation. The doctors in California did it right. They treated him as they did appropriately, but the patient didn't say much about his back pain. And even if he did mention the back pain, it's so nonspecific, we're not 100% sure what it could have been, right? And then this red urine with the hydroxycobalamin that came about, what if he never mentioned anything about blood in his urine, and then he's given this hydroxycobalamin, and now it's more difficult to find blood in his urine, even though it is in the urine analysis, but we're not 100% sure what that was at that time. If you look at it, all of this added up into really kind of a tragedy for this patient, because even though he appeared to recover okay initially from nephrectomy first, 3 weeks later, after surgery, the patient died. And so the final thing I wanted to bring up in this case that I had mentioned at the beginning was on page 2, can you tell me about some of the other possible lab abnormalities? What would you add to your problem list based on that? And here's the interesting thing about this. If you're able to identify what it is, what appears in the differential might have changed the course of treatment for this patient at that point in time. And so if you're able to look through it, if you have some time, I know you're studying for the semester, if you have some time to look through it and look a little bit more closely, you can send me an email and you can let me know what your guess is, and I'll send you a little bit of a write-up to tell you if you were right or not. And if you're not right, it's okay, no worries. We'll talk more, we can discuss more in the email about what could have happened had this particular problem been found earlier. Thanks.
Thanks so much. That was awesome. We want to open it up to Q&A. I don't know how long people have. I know that Matthew had a question. If you want to ask first.
Yeah, so bringing up kind of the point that he had symptoms before he came into the hospital, that he had these symptoms before he was in the house fire. Is it common practice for physicians to ask patients before, like, what their symptoms were before a traumatic event? For example, if somebody was in a car crash and you know that they had major trauma, would it be common for a physician not just to ask for what their medical history was, but if they had any concerning symptoms leading up to this car crash? Because I feel like that could also be something that would be preventative in some way for trying to make a complete diagnosis.
Yep. And so in the pathways of care for this patient, he was unconscious in the emergency room and then transferred to the medicine unit in step down afterwards. So there's a little bit of a disconnect between the two. And so by the time you have this patient regaining consciousness, the initial doctor who admitted him is a different person now. And so they might not have that communication and follow up between each other, because now you're looking at different areas of the hospital. And so that's where some of the gaps.
I hear you for some reason, Bernard.
Mm-hmm. You can't hear him?
Okay, here.
Can you hear
Sorry.
me?
I can hear you now. Yeah.
Oh, okay. Yeah, so this patient was unconscious when he was admitted into the emergency room. And then when he was moved in to the step down unit on the medicine service, those are two different caregivers. So that the pathway to care is a little bit different. And sometimes the communication is difficult because this is a patient who is unconscious. So he wouldn't have been able to tell the initial emergency room physician what had happened. And so that's why there's the suspected cyanide and carbon monoxide poisoning. And then the management inside of the medicine service might have just been a little bit different. And when he woke up, he might not have necessarily said, "Oh, I've been peeing blood for 2 weeks," right? He may have just been concerned with, getting out of the hospital and, recovering from this toxic gas inhalation.
I was wondering
Yeah,
where
that 100% makes
cyanide
sense.
comes from. Like, where's the cyanide? Is it in the wood?
Yeah,
I know that cyanide was a concern with fires.
Yeah, some of the furniture and building materials have cyanogens in them. So cyanide poisoning is it's really kind of rare here in the United States, but you find it mostly in burning buildings or also industrial accidents.
And then can I ask one more quick question?
Yep.
Just in terms of whenever we're physicians and we're further along in our careers, do you have any advice as to kind of like continually educating ourselves in terms of finding research articles and staying on top of what's new? I feel like you would have a good idea in terms of how to make sure we're at the top of our game after our medical education.
Yeah, and especially teaching at the university, it's really up to you to keep up to the medical journals, because that's where the primary source of information comes out. When you look at the phase 3 clinical trials that got published, that inevitably gets into the guidelines for whatever specialty you're in, and then that'll start to change how you practice. So what you learn and what gets taught in the schools is, you hear about practice changing studies, things that have high impact. And so a lot of those come from the phase 3 randomized clinical trials. Depending on which branch of medicine you do end up practicing in, it is different. So I guess just give you an example. In toxicology, a lot of it's case reports. You can't induce poisoning in somebody to test an antidote, right? And so you have to catch somebody who happened to be poisoned at a specific time, and you had to have had that trial rolled out and initiated at any one of these hospitals, which is already like a logistical nightmare. And so toxicology, it's really difficult to have high level of evidence in any of the treatments that come out. In oncology, for example, if you subscribe to New England Journal, and like I'm sure at Georgetown you can log into New England Journal and probably start to read some of it. If you look at it, there almost every week, Wednesday at 5 p.m. Eastern time, you're going to see that New England Journal has published their latest issue. You'll almost always find like an oncology trial in there, because there's so many of them going on now. And so if you look at it, it's maybe a smaller patient population. You might have 40 or 50 patients, testing some new immunotherapy. And then if you read that, you'll find that a lot of times in the recommendations for ASCO or the NCCN guidelines, we'll then start to use these medicines based on the level of evidence that was created in that trial. And so by keeping up to date on that, you'll have a better sense of what's happening with your field in medicine. And also, if you're at an academic center, you might be involved in initiating and creating one of those trials, because some of the faculty positions will require you to do some research. And so by doing that, you'll be one of the ones who will be creating the new medical knowledge based on some of the trials that would be initiated at the site.
Awesome, thank you.
Cool. Thank you so much. Does anybody else have any questions? I know it's a little bit longer than our usual meetings.
Oh, sorry.
Yeah, I have a quick question, if that's okay.
Yeah.
So maybe I missed the detail of how long it was between the first hospitalization and the second one. But do you think that if by some miracle the doctors in California were able to catch that it was this type of renal cell cancer, that it would have made a difference in his prognosis, or do you think he was already like too far gone?
Yeah, that's a good question. So that actually goes to one of the follow-up questions. So you're already ahead of the game. It's possible that he would have, because there were 8 weeks in between here. Let's see if we go right. So 8 weeks after hospitalization and returning east, his urine is still red. And so because he developed trouble breathing, it's possible that the lung metastases developed during that time. And so you're looking at potentially what could have just been stage 3 if it was lymph node involvement only, to now stage 4 with the pulmonary nodes. So if you have that, you're upstaging the disease. And if you look at the prognosis for going from stage 3 to stage 4, it's usually decreased by a lot. But regardless, this cancer, if caught early, can be fine, but it's usually caught late. And so this kind of presentation is pretty typical, that it's not until you have widespread metastases that it gets diagnosed. But you're right, it could have come out better had they caught it. And there's a link to that with the questions right here.
Thank you.